Good morning. Can everybody hear me okay? This is Dr. Ramana Moorthy. I'm calling from holding this conference from Indianapolis, Indiana. I want to thank everybody at CyberSite, Orbis, and Lauren Sika in particular for putting this all together. And thank you, Dr. Neely, for inviting me to talk. Today, the topic is going to be on uveitis, and this is one of the first lectures, I think, on uveitis that we're doing. So I will, we will keep the questions to the end. I think just in the interest of time, we have a lot of slides to go through, and then we'll try to anticipate any questions, et cetera, that you may have. There are a few questions that we'll do during the talk as well. So today the talk is going to be on trying to work up a uveitis patient. How do you approach a patient that has intraocular inflammation? How do you do a laboratory workup? And what is the sequence of events that we go through when we see a patient who has inflammation in and around their eye? We classify uveitis today into the broad categories of non-infectious uveitis or infectious uveitis. Non-infectious refers to those where there may be some underlying systemic immunologic abnormality, or as we see in most cases, idiopathic, where something has initiated the inflammatory event in the eye, and this could be an environmental antigen or pathogen, but that is long gone. But this ongoing inflammatory disease process in the eye, because of the immune privileged environment of the intraocular structures, results in propagation and potentiation of a lot of inflammatory cells, and the inflammation continues and needs to be treated because it causes structural damage. Infectious uveitis, on the other hand, has a direct cause, a viral, bacterial cause, such as syphilis, TB, Lyme disease, for example, a fungal cause, protozoal cause, helminthic causes, etc. We also can classify uveitis into masquerade syndromes, where there are non-neoplastic masquerades like retinitis pigmentosa that can sometimes look like intermediate uveitis, or neoplastic masquerades like primary intraocular lymphoma or primary CNS lymphoma involving the eye. We can also classify uveitis anatomically or based on time course. For example, anterior uveitis, the inflammatory cells are mainly seen in the anterior chamber. Intermediate uveitis, the inflammatory cells in the vitreous. Posterior uveitis, we'll see inflammatory cells involving the vitreous. The retina and the choroid can be involved as well. And in panuveitis, there's inflammation of all of the uveal structures with no preponderance of cells in any one particular location. And of course, the time course of uveitis can be separated into acute, chronic, or recurrent. Acute cases are those cases that last less than 3 months. Recurrent cases, and this is based on the criteria that were developed by the standardization of uveitis nomenclature back in the early 2000s. And this recurrence indicates that, you know, the patient has gone more than 3 months from the initiation of the first episode, has been off of medications, and then has a recurrence of disease 3 months after the first episode. But if they have recurrence of disease, stopping medications, and then they get a recurrence immediately, well, that's more of a chronic or relapsing disease. So chronicity indicates that the inflammation never really completely went away. This is a picture of a patient who has anterior uveitis. This picture is from Dr. Emmett Cunningham. He shared this with me, and this is a beautiful picture of anterior chamber cells. And see, you can see the tremendous amount of cellular inflammation, which should be differentiated from flare, which is caused by the so-called Tyndall effect, which is actually the substance to the actual beam of light that is traversing the eye. And this is a good way to judge the amount of cells. A 2 millimeter by 1 millimeter wide beam on the highest intensity using a slit lamp is a good way to judge the number of cells in the anterior chamber. So here's the first poll question I have. What is the most common anatomic type of uveitis encountered in clinical practice? 1, intermediate uveitis. 2, anterior uveitis. 3, posterior uveitis. 4, panuveitis. And this is for in general practice. And we'll see what this what the poll shows us here. So the most common cause or most common anatomic type, excuse me, of uveitis that is encountered in clinical practice is anterior uveitis. Probably 2/3 to 3/4 of cases of uveitis that we see in general clinical practice are anterior uveitis. In specific subsets, for example, in children, intermediate uveitis is the most common form of uveitis that we can see, specifically the idiopathic pars planitis. Posterior uveitis, and I think everybody got that right. That's great. I can see that, so you guys are beyond that, that topic, so I won't spend too much time here with that. So, you know, the posterior uveitis and panuveitis are less common. The most common posterior uveitis that we typically see is posterior infectious uveitis is toxoplasmosis. The key to determining what causes the uveitis is really to first obtain an accurate and thorough history and perform a thorough ophthalmic and physical examination on the patient. And I can't stress this enough. When I speak to residents, I tell them that, you know, we want to all jump in and say, well, this person has uveitis and I'm going to do a so-and-so labs. Well, the labs don't mean anything when they're not put in the proper clinical context. So it is very important to obtain a thorough history of the ocular events, what has happened, what has transpired in this patient, and try to tie in with a thorough review of systems, not just the ophthalmic review of systems, but the non-ophthalmic review of systems to try to help you determine what is the underlying cause of the inflammation, because determining the cause and specifically making sure that you know this is not infectious uveitis is very, very important. Because if it's infectious, the treatment should be obviously geared towards using the appropriate antimicrobial agents to treat the infection and then initiating corticosteroid therapy after you started the anti-infective therapy first and getting the patient better. Laboratory testing, of course, can be helpful in confirming and narrowing the spectrum of the etiology, but they're not a substitute for this history and physical examination. And, you know, if you suspect an infection and you can't prove it's an infection, it behooves you to do the appropriate testing, and sometimes that involves invasive testing, such as obtaining aqueous or vitreous cultures. And if neoplasia is suspected, tissue biopsy is obviously essential in the management of the patients. So when we look at, when I do a comprehensive medical history, I really do a thorough evaluation, for example, of what drugs the patient is seeing, what are the current medical problems that are active in the patient, and also, is there a history of autoimmune disease? Is there prior ocular surgery that can tell me, hey, this patient had multiple retinal surgeries in one eye and now presenting with panuveitis in both eyes? This could be sympathetic ophthalmia. A complete review of systems is very important. And let me briefly, kind of in a nutshell, explain what that review of systems involves for me. I start with the integumentary system. I ask the patient, had they had any unusual skin rashes, any lumps or bumps underneath the skin that are painful, any painful red nodules underneath the skin. Is there been any history of mucosal ulcerations, such as oral aphthous ulcers or genital mucosal ulcers? Is there any history of previous arthritic symptoms? For example, is there axial arthritis? Is there distal arthritis in the hands, in the fingers or toes, in your feet? Where is the arthritic symptoms? Where are they? How long have you had them? And how have they been treated? Is there a history of chronic cough, sputum production, hemoptysis, a previous chest x-ray, history of TB exposure, or a positive PPD skin test or quantiferon test in the past? Is there a history of chronic abdominal pain, recurrent diarrhea, blood and stool, change in bowel habit, things like that that may point towards inflammatory bowel disease? Is there a history of recurrent urinary tract infections? Is there any history of travel, significant travel to unusual locations in the world? For example, have you spent the last 6 months camping in the high Sonoran deserts of North America, where you may be more likely to be exposed to coccidioidomycosis? Have you been to areas where you've drunk unfiltered water, for example, where toxoplasmosis may be endemic? Those kinds of things are very useful. any existing pets, for example, you have cats at home, or any unusual pets or veterinary exposure. Those are all parts of the review of systems that I do. A family history is sometimes helpful. For example, when we're looking at patients who have Blau syndrome, for example, where the familial form of sarcoidosis, we often will see that there may be siblings that have inflammatory disease at a young age in the family already. A social history of smoking, of course, is very important, and occupational exposure and drug use, IV drug use, et cetera, or illicit drug use is also very important. Smoking obviously potentiates and makes chronic inflammation worse, so we need to know that for management purposes of the patient as well. So I've talked about the review systems here. Also, I asked about systemic illnesses currently or ongoing, fevers, chills, weight loss. And I also talked about the organ system involvement. Immunocompromised state. Are they being treated currently for cancer? Or have they had exposure to HIV or high-risk behavior that might put them at risk for HIV? And are they, do they look malnourished? Are they on hyperalimentation or other things because of underlying other chronic medical conditions? See, these are all very, very important parts of the consideration of etiologic evaluation. Then, of course, the examination is pretty standard, what you would do for everybody else. But, you know, in the uveitis patients, you need to put all of what you've learned in ophthalmology together, because uveitis, unlike other entities, involves and could produce complications in all of the broad categories and subspecialties of ophthalmology. It can cause cataracts, it can cause glaucoma, it can cause retinal structural abnormalities, including retinal detachment, cystoid macular edema, neovascularization. All these things are important, so we have to do a very thorough examination of the patient. Best corrected vision, pupillary functions, motility, confrontational visual fields. And then at the slit lamp examination, looking specifically at the conjunctiva for nodules or granulomas that might indicate sarcoidosis or TB. Corneal changes that might indicate herpetic disease, such as epithelial disease or stromal infiltrates. Presence of KPs, their distribution, their size. If they're diffuse and small and dendritic, this may indicate Fuchs heterochromic iridocyclitis, or even perhaps Cytomegalovirus Retinitis posteriorly. What are the colors of the KPs? Pigmented KPs may indicate herpetic disease or old chronic inflammation. The anterior chamber depth, whether there's presence of angle closure, iris bombay, whether there is presence of broad peripheral iridocorneal adhesions indicating chronic inflammations, or posterior synechia, for example, in the iris. We may also want to look at the cells in the anterior chamber, of course, and look for the presence of hypopyon. Pull down the lower lid. Even put a gonio lens on, look at the inferior angle to see if there's a microhypopyon forming. Is there a hyphema? Are there pigment cells that should be not confused for inflammatory cells? Is there significant flare, enough to cause fibrin, for example, that may tell us, hey, fibrinous iridocyclitis is probably HLA-B27 if it's unilateral and associated with low back pain. So these are all important considerations when viewing the anterior chamber. You want to look for rubeosis, iris neovascularization. You want to look also at the iris contour, heterochromia, atrophy. Heterochromia can be very difficult to see, so you should turn on the lights in the room and look at the patient and get a gestalt of whether or not there is heterochromia if you suspect there's Fuchs iridocyclitis going on. Look at the extent of posterior synechia. Document the location of the posterior synechia so that you know what things look like in follow-up. Whether or not there are Kepi nodules on the iris border or Busacca's nodules in the midstrome of the iris, and the presence of cataract and the morphology of the cataract. In addition, of course, applanation tonometry, looking at the intraocular pressure, and evaluation of patients by gonioscopy is particularly important, especially if there's elevated IOP or hypotony, and whether there's if there's a significant presence of structural damage to the iris with posterior synechia. Look in the angle and look by gonioscopy for peripheral anterior synechia, because these patients may be at risk for developing glaucoma and with combined mechanism. Look at the macula for cystoid macular edema or retinal thinning or atrophy. You may use the OCT, of course, to determine how much macular edema there may be. Look at the retinal vessels for sheathing, vascular occlusion. Look at the retina for retinal whitening, retinal edema. retinal inflammation. Look at the choroid for old chorioretinal scars, active chorioretinal scars that may look white or creamy. Look at the optic nerve for optic disc swelling or neovascularization on the optic disc, and examine the retinal periphery, looking for peripheral neovascularization, retinal detachments, evidence of pars plana exudates in patients who may have pars planitis, such as a snowbank or vitreous snowball opacities in the periphery. Still, if you're confused about, after doing the history and physical examination, what is this inflammation? Obviously you've anatomically categorized it at this point. You might be able to kind of differentiate what this inflammation may be caused by based on laterality. For example, you need to consider in unilateral cases that herpetic disease from HSV, VZV, cytomegalovirus, or toxocariasis, toxoplasmosis is more common. Not always helpful to think that it's infectious if it's unilateral, because there are many cases of non-infectious entities that are bilateral, and non-infectious entities that can be unilateral. For example, HLA-B27 anterior uveitis, the most common identifiable cause of Hypopyon uveitis. In those cases, it's unilateral in presentation. Scleritis can sometimes be unilateral, and it's not infectious. So just because something is unilateral doesn't necessarily mean it's always going to be infectious, but infection rises to the top of the list, especially herpetic infection. If you have identifying features that suggest that there's sectoral iris atrophy, corneal scarring, things like that, that might suggest that you might have herpetic disease as the underlying cause. Use non-ocular clues as well to help you in the diagnosis. So once you've done the ocular exam, look at the patient. Do they have a vesicular dermatomal rash to suggest that it's zoster? Or zoster ophthalmicus, like the patient that you see on the top picture. The middle picture is the exanthematous infectious rash that you see on the palms and soles in a patient who has secondary syphilis. Be careful about shaking hands with these patients, obviously, because there are active spirochetes in that rash. And look at the patient's extremities for evidence of a ixodes bite, for example, that might be associated with Lyme borreliosis. Here you can see the classic picture of Lyme borreliosis with the target lesion. Here is a patient who has very severe psoriasis with large plaque-like psoriatic lesions, and this patient had anterior uveitis in both eyes, and this patient was HLA-B27 positive. This can give you a clue as to the etiology. Look at the lacrimal gland for inflammation and enlargement, as in this patient with dacryoadenitis from sarcoid, or parotitis. This patient has Herford syndrome with enlarged parotid gland. You can see the dramatic appearance of the patient's enlarged woody parotid gland and the active inflammation that she had panuveitis in both eyes as well at the same time. Is the hypopyon sterile, infectious, neoplastic? When you see a hypopyon, you can't assume automatically that it's endophthalmitis. There may be other things going on that will tell you and give you features. For example, if they're 5 days post-cataract surgery and they have a hypopyon, they have pain and vision loss, it's pretty easy to suggest that they have an infectious endophthalmitis. But if the posterior segment looks clear, the vitreous is clear, and they just have an isolated hypopyon, well, you need to think about the possibility of HLA-B27. So in the cases of infectious uveitis, the most common things that we see have patterns. Toxoplasmosis, for example, has a pattern of unilateral focal choroiditis. But also remember that focal choroiditis unilaterally, especially in kids, could be Bartonella-Hensley. Bartonella-Hensley's most common presentation is not neuroretinitis, but unilateral focal choroiditis. Varicella zoster virus and HSV can cause anterior uveitis associated with corneal changes or iris changes, increased intraocular pressure, and diffuse KPs. These are all clinical features that are very typical of unilateral cases of viral anterior uveitis or viral anterior uveitis associated with other changes that suggest VZV or HSV. Late onset endophthalmitis based on history. Somebody who's pseudophakic who can't get off topical corticosteroid drops for 2 years and has subcapsular opacities, this suggests that the patient may have propionibacterium bacterium acnes associated chronic endophthalmitis. If the patient has a necrotic granuloma in the posterior pole and has been sick or ill, has been or has been an IV drug user, you might think about the possibility of Aspergillus endophthalmitis. A patient who has history of HIV, who presents with vision loss and floaters and has evidence of necrotizing retinitis with retinal hemorrhages, and a pizza pie appearance, that's cytomegalovirus retinitis. But they can also look granular or brush fire or even have a frosted branch angiitis appearance. Toxoplasmosis, you can see as a peripheral granuloma, a focal macular granuloma, or a diffuse endophthalmitis type picture as well. If you're still not sure, combine what you know about the history with the pattern recognition to try to determine the underlying cause. So here's a picture of a Hypopyon. How would I know what's causing the Hypopyon unless I ask the patient, hey, I've been treated with rifabutin for the last 6 months for a Mycobacterium avium infection. So this patient, has HIV and has been on rifabutin. So this patient got a rifabutin-induced or drug-induced Hypopyon on the top left. And here is the patient on the top right that actually had cataract surgery 3 days ago and presents with pain and vision loss with severe redness, ecchymosis, chemosis of the conjunctiva, and this is all suggestive of infectious endophthalmitis. Oh, here's a patient on the bottom left who had an intravitreal injection of Kenalog literally 2 days ago, and he presents with vision loss. This patient actually just has a pseudohypopyon from presence of Kenalog particles in the anterior chamber. See the white, stark, beautiful clinical appearance. There's a little bit of fibrin in the anterior chamber too, which is probably why he had received the Kenalog injection. And you can see in the bottom right, a patient who has the classic Hypopyon of Behçet's disease. This patient actually had a shifting Hypopyon. Behçet's, if you have the patient sit up and shake their head and look at them at the slit lamp, the Hypopyon disappears. So it's not a congealed Hypopyon that you may see with the HLA-B27 or with endophthalmitis. And you can also look at the vitreous. Is there significant vitritis? Does that help you? Does it help you that there are vitreous snowball opacities there? Are there choroidal lesions there in the retina, et cetera, that can help you? Here's a typical case of Toxoplasma Retinochoroiditis in a young 10-year-old boy who presented with focal choroiditis. You can also see adjacent vasculitic infiltration adjacent of the retinal vessels. You can see along the retinal vessels here. I don't know if you can see my arrow, but you can see this vascular sheathing. This is called Choroditis vasculitis, which is very commonly associated with toxoplasmosis. But remember, Bartonella should be a consideration in children who have such changes as well. So Bartonellosis should be considered and serologically evaluated in those patients. Here's a patient who has tuberculous panuveitis, but I've seen patients who have syphilis that look the same way. So this patient has a history of having active pulmonary TB and has multifocal choroidal miliary nodules in the posterior pole, in the choroid, and has significant vitritis, larger granuloma inferior temporally here that you see, and these miliary granulomas are on the macula. There's a vitreous hemorrhage, there's neovascularization on the disc. This is a very complex patient with tuberculous panuveitis. Here's another patient. This is something that we see very rarely in the United States, but it's more common in places like India where TB is endemic, where here we see multifocal tuberculous serpiginoid choroiditis. This is a patient that in the early stages looked more like serpiginous choroiditis, but this patient clearly had active tuberculosis. That was proven based on PCR studies inside the eye. This patient had severe inflammation in the vitreous along with changes of this multifocal choroidal inflammation. But this is a pattern of TB that should not be missed. And anybody with serpiginous choroiditis, you should be considering TB also in the differential diagnosis. Here's the classic neuroretinitis presentation with macular star formation and ocular Bartonellosis. And this is another very classic presentation, although not the most common for Bartonella. And here's the classic pizza pie retinal necrosis and hemorrhage that you see in association with Cytomegalovirus Retinitis in a patient with HIV/AIDS. Here's a patient who has acute retinal necrosis syndrome or necrotizing herpetic retinitis in an immunocompetent individual, where we see thumbprint style retinal necrosis along with evidence of perivascular clearing, giving this cracked mud appearance later in the later stages of the disease. And here's a clinical picture of a patient who had all of the findings that are classic for what? Behçet's disease, right. Oral aphthous ulcers, Hypopyon, retinal vasculitis here you see with the venular involvement, and here almost a necrotizing retinitis appearance because of retinal vasculitis from Behçet's disease. And so this is a clinical diagnosis based on the presence of multiple clinical criteria and not a blood test. this patient may have been HLA-B51 positive, but that's not what led to the diagnosis of Behçet's disease. It's a clinical diagnosis. So, and here's another clinical diagnosis. This patient has Vogt-Koyanagi-Harada syndrome. Exactly. This patient has evidence of significant disc edema, evidence of severe thickening of the choroid, serous retinal detachments, and the fluorescein angiogram is quite characteristic of the starry sky pattern of focal leakage from multiple spots in the posterior pole with late pooling of fluorescein in the subretinal space in these areas of serous retinal detachments. And here you can see in the later stages of the disease, in the convalescent phases of the disease, the presence of poliosis of the eyelashes and vitiligo of the eyelid skin in this patient who has a sunset glow fundus, and evidence of small punched out chororetinal lesions in the periphery, especially inferiorly. This is all typical changes that we see from multifocal choroiditis from Vogt-Koyanagi-Harada syndrome. Here's a patient that I showed you earlier with psoriasis, severe psoriasis, who's HLA-B27 positive, who presents with this dense fibrinous Hypopyon associated with fibrinous iridocyclitis, and this is a patient who's B27 positive, HLA-B27 positive. He also has ankylosing spondylitis and axial arthritis involving his sacroiliac joints. This is a 5-year-old patient, a very tragic case, presents with severe vision loss with a white, quiet eye. What's the diagnosis? Exactly. This is juvenile idiopathic arthritis. This is a young person who is pauci-articular disease, who has evidence of calcific banded keratopathy, chronic anterior segment inflammation that has been untreated or poorly treated with structural changes and damage and blindness, very high risk for severe vision loss and even loss of the eye. In these kind of settings. These kinds of patients need to be caught early, screened frequently, caught early, and treated. So let me move on here. And so let's talk a little bit about what kind of lab test would you do for the generic patient who presents with uveitis, okay? So every uveitis patient that you're going to work up should be worked up for which of the following conditions? 1, rheumatoid arthritis and systemic lupus. 2, HSV, VZV, cytomegalovirus infection. 3, toxoplasmosis. 4, sarcoidosis, syphilis, and tuberculosis. What is the right answer? And, you know, I think we'll look at what people have responded here. We'll give it a minute or two here. But, you know, I think that as we talked about, all of these things are potential things to consider in the right setting, but there are 3 entities that should always be evaluated in patients who have uveitis, and that is sarcoidosis, syphilis, and TB. These are important because syphilis and tuberculosis are treatable and important for from a both a public health perspective. Let's talk about this a little bit more because it looks like we kind of have a smattering of responses. So any patient who has uveitis, let me ask, rheumatoid arthritis and systemic lupus typically will not cause anterior chamber inflammation, will not cause vitreous inflammation. These kinds of diseases, systemic lupus and rheumatoid arthritis, can cause scleritis. They may rarely cause retinal vasculitis, but rarely alone do they cause inflammation with cells in the anterior chamber or vitreous, or the so-called uveitic inflammatory disease. Now, HSV, VZV, and cytomegalovirus infection, well, you know, lab testing for those would probably not involve serologic lab testing. I should have been more specific in my question. Certainly, these are things to consider based on the clinical appearance, but these are not typical labs that we'll obtain on a patient. Toxoplasmosis, I check that if it's appropriate based on the clinical appearance of the patient. So, but every patient who has a, you know, inflammatory cells, if you're going to work them up, you need to rule out the possibility of sarcoid, syphilis, and TB, because these diseases, again, they can masquerade as multiple different forms of uveitis, and syphilis and TB in particular have broad implications in terms of their curability and their social treatability and the associated social aspects of these diseases. So these are very important to identify these 3 conditions, systemic conditions or infectious inflammatory conditions. So every uveitis patient that has a workup should be tested for sarcoid, syphilis, TB, SST. Just remember that. If you remember one thing from this lecture, I want you to take that away, okay? So what kind of tests do you do for syphilis? Well, syphilis testing involves serologic tests that are specific for treponemes. In other words, you want to get treponemal-specific testing such as FTA, microhemagglutinin assay for treponeme pallidum, or more commonly now what's available is anti-treponemal IgG antibodies, which has replaced the FTA in most places in the world, and at least in Western Europe and in North America. So syphilis testing should be specific for treponemes. Okay, so there are lots of false positives for syphilis testing. It's beyond the scope a little bit of this, but I'll talk about this. But obviously patients who have lupus, who have other autoimmune diseases, and women in particular may have a higher rate of false positivity for this testing. But the FTA is very important. Remember that syphilis, if it causes uveitis, it's going to be post-primary syphilis, either secondary or tertiary syphilis. So these patients have already had primary syphilis, so their non-specific markers such as VDRL, the VDRL is going to be only transiently serologically positive, and within a few weeks will be negative. The FTA, however, starting within a couple of weeks, will be positive and remain positive for the lifetime of the patient. So that's why it's important to look for those, because secondary and tertiary syphilis, we're going to be seeing positive FTA and not necessarily positive VDRL. So when you say I've checked for syphilis, make sure you're talking about treponemal specific testing. Sarcoidosis testing is of some controversy, but if the patient has pulmonary symptoms of chronic cough, weight loss, they have evidence of enlargement of the salivary gland, or of lymphadenopathy, or evidence that they have lacrimal gland enlargement, an ACE, an angiotensin-converting enzyme level, a lysozyme level, a serum calcium level, and a chest X-ray can certainly be part of the workup that can be very easy to and helpful in ruling out sarcoidosis. The blood test alone can't be diagnostic. Tissue is diagnostic for sarcoid, and you need to show evidence of conjunctival granulomas, for example, that are non-caseating granulomas based on the histopathologic evaluation. And of course, in a histopathologic evaluation of sarcoid granulomas from the conjunctiva, you need to rule out other things like foreign body and fungus and tuberculosis. So by using acid-fast testing on the histologic specimen. TB, how do we test for TB? There was a question about how about quantiferon. Yes, in endemic areas of the world, we still tend to rely on simple testing, tuberculin skin testing, and if the patient has been treated with BCG vaccination, as they are in many places like in India and sub-Saharan Africa and those places, well, it may be important to obtain an interferon gamma release assay, quantiferon gold or quantiferon TB, or a TB spot, or T-spot TB, excuse me. That testing has in the United States replaced PPD testing, and it can be very, very useful. If a patient has had previous BCG vaccination, a PPD may not be reliable, and in those cases, an IGRA or interferon gamma release assay such as quantiferon TB is very important. A chest X-ray is very important. But remember, testing for TB, you have to be very careful, because does the clinical appearance of the uveitis match tuberculosis for you to suggest that this is TB? Now that can be very difficult because TB is a masquerader. TB can present as anterior uveitis, can present as intermediate uveitis or perisplenitis. So these patients, if they have a quantiferon gamma release assay that's positive, there's no previous history of being treated for TB or vaccination, I would also check their PPD. Do they have a significant skin reaction on their PPD? So don't bypass the PPD even if it's an old test to confirm if the quantiferon gamma release assay is of significance, especially in endemic areas, etc. We need to look at the chest X-ray, look at the PPD, and look at the clinical appearance of the patient before making the decision that this is tuberculous uveitis. In addition, I think it's very, very important to check in specific disease conditions for HLA-B27. Now, I normally do not obtain an anti-nuclear antibody tested in an adult who presents with anterior uveitis because lupus doesn't cause that. But in a child who has chronic iritis or chronic iridocyclitis, you know, we know that we're considering in that condition that juvenile idiopathic arthritis is an important player and an important condition to rule out. So we're going to check an anti-nuclear antibody because patients who, especially girls who have polyarticular JIA, will be ANA positive. Those patients are going to be the ones that are going to have anterior uveitis. This is a picture of the fluorescent treponemal antibody test where the treponemes are immobilized by the antibody in the syphilis testing. This is a kind of an overview of the assays that are done for cell function for ELISA, using the quantiferon TB using ELISA or the ELISA spot or T-spot TB test, where we obtain blood samples from the patient and actually stimulate them with mycobacterium tuberculum protein and then look at the interferon gamma that's produced in a couple of different ways to determine if the patient has revved up T cells that are producing enough interferon gamma to suggest that the patient has more than just latent previous TB exposure, but actually latent disease or active disease. So this is very, very helpful for latent disease. Active disease, you're going to see signs of active disease clinically that needs to be put together. Sarcoidosis, a chest x-ray can be very helpful to grade the stage of the disease. For example, if they have just hyaluronidenopathy in stage 1 or if they have interstitial lung disease of various stages of severity. And the same goes for tuberculosis as well. We can also use, if we're still suspicious of infectious etiologies and we want to look specifically for underlying pathogens in the aqueous fluid or vitreous fluid, many of us now rely on the use of polymerase chain reaction testing. PCR testing can be very, very useful if you suspect that the patient has viral disease such as HSV, VZV, CMV, if they have toxoplasmosis. The usefulness of aqueous taps for patients who have infectious posterior uveitis is of some question. And in those cases, you need to go to where the action is. So if the patient has vitritis and posterior uveitis, the best PCR samples are probably going to be derived from the vitreous. So, you know, the diagnostic testing, once you've ruled out the TB, syphilis, sarcoid, what else can you do? What else can be helpful? Well, based on the clinical appearance, and the history, I would taper what other testing you get. Do I get toxoplasma antibody titers? Is the clinical appearance suggestive of toxoplasma, toxocara? Is there a history of you know, going into endemic areas of Lyme, such as in western Wisconsin in the United States, or in the northeastern seaboard region of the United States where Lyme is more endemic? Or are there other non-ocular clues or other non-uveitic clues in the cornea or the iris that suggest that the patient may have HSV disease? In those cases, we may obtain specific testing for viral etiology. Remember that serologic testing for HSV, VZV, and CMV is really only helpful if it's negative in ruling out a diagnosis, because most adults are going to have positive serologies to these viruses from previous exposure. I have a few questions I'm going to just kind of break off here. So yes, many of you don't have all of these testings readily available where you are. If you're in remote Mongolia, for example, you know, we don't have all of the testing, et cetera, and rely more on history and physical examination. But ultimately, at least if you had to pare down to the most minimal things that you need to check for, the sarcoid, syphilis, TB is the bare minimum. So if you can't get a blood test for sarcoid, it's not available, a chest x-ray may be very, very useful. A TB skin test is very useful. And certainly minimal testing for syphilis using treponemal specific antibody testing is really, I think, very, very important. Torch screening may not be as useful in cases where you're reliable testing for uveitis, especially in adults. And of course, you know, the testing that you do for diagnosis of Bartonella, we do Bartonella serology. We look for Bartonella henselae, Bartonella quintana, IgG and IgM titers. These can be very, very helpful with recent onset disease. I'm going to move on here so we can get to some of the cases I wanted to share with you. I think we're getting a little bit late into the course here. You know, I think there's other additional serologic things that can be helpful in delineating what the patient has. You know, we talked about the ACE and lysozyme being not as useful and only if combined with a chest X-ray that's positive and the histopathologic evidence of sarcoid that's positive. HLA-B27 can be very helpful in acute fibrinous hypopyon cyclitis, and it's a very common cause of this. In unilateral cases, you need to think about that. In teenagers who have bilateral ocular inflammatory disease, who present with intermediate uveitis, I think about the possibility of tubulointerstitial nephritis and uveitis syndrome. Here we can use the urinary beta-2 microglobulin test to determine if they have interstitial nephritis. The interstitial nephritis can be transient, and the uveitis can be persistent. There are no serologic tests for things like sympathetic ophthalmic, VKH, and Behçet's. These are all clinical diagnoses. And in the case of scleritis, well, I do check rheumatoid factor, anti-nuclear antibody, anti-double-stranded DNA antibody for lupus, and P-ANCA and C-ANCA for specific vasculitic conditions. And I use ANA and rheumatoid factor testing in a child who has chronic anterior segment inflammation if I'm suspecting JIA-associated disease. PCR testing we've already touched on, but there are numerous things that are available. The most common readily available PCR testing in most labs in North America and Western Europe are those for HSV, VZV, cytomegalovirus, and Epstein-Barr virus, and Toxoplasma Gondii. There are now in certain specific large academic centers in Western Europe and North America, and even in academic centers in Asia, in Southeast Asia, we can have access to pan-fungal and pan-bacterial primers with multiplex PCR technology now being available, with very tiny quantities being able to deduce underlying forensic DNA analysis of the aqueous, if you will, that can be very helpful in delineating what the etiology of the inflammation may be. I'm going to move quickly on a little bit and touch a little bit about therapy because I think it's important. Because if you're in the midst of the work of a patient with uveitis, the statement here is a true or false statement. Corticosteroids should never be used alone in the treatment of infectious uveitis. Is that true or false? Let's see what you guys all thought. Yeah, so, you know, corticosteroids should never be used alone. The key is alone. If you suspect that the patient has infectious inflammatory disease, you don't want to give them, and I'm talking about systemic intraocular or periocular corticosteroids. You should never, ever do that to treat a patient who you suspect has infectious uveitis. If you think it's infectious, it's probably reasonably safe to put them on some topical corticosteroids, but you need to think about adding some sort of systemic anti-infectious agent, antimicrobial agent. If you think it's viral and it's HSV or VZV, you may want to add acyclovir or some variant of acyclovir. If you think they have Bartonella, or if you think they have syphilis, you need to choose the appropriate antimicrobial agent first. Treat them first with the systemic antimicrobial agent, and then go on to treating the patient with something more aggressive in terms of corticosteroids based on what you find in the evaluation of the infection. So once you've found that the patient is infectious, you have them on antibiotics. Do corticosteroids have any role? So the question now is, corticosteroids have no role in the treatment of infectious uveitis. Is that true or false? And so this is a little bit of a trick question. It's a fine point, and I'll try to clarify this. And obviously, anytime you have inflammation, you're going to use corticosteroids. But the question is when to initiate corticosteroids. If the patient has infectious uveitis, always, always, always treat them with the infectious agent first, okay? And then use the corticosteroids. That's right, use the corticosteroids then to treat the inflammatory component. We know that the host inflammatory disease is what causes the damage in cases of infectious uveitis. So in other words, when you see a patient with endophthalmitis, you don't treat that patient just by giving them intravitreal antibiotics alone. You treat them, you follow that up with intensive topical and sometimes more aggressive corticosteroid therapy to help reduce the inflammation that results from the death of the bacteria. So therapy should be in the case of infectious uveitis, directed towards the agent, and then later addition of corticosteroids. Sometimes you have to use very aggressive periocular, intravitreal, or systemic corticosteroids to control the infectious uveitis once you put them on antibiotic therapy. Neoplastic masquerades have to be diagnosed based on histopathology. So pars plana vitrectomy, sometimes subretinal biopsy for patients who have primary CNS lymphoma is essential, and you have to communicate with your pathologist when you're doing the surgery and obtaining the specimen in order to make the diagnosis. If you don't have a pathologist that's competent, or you don't talk to the pathologist, they're not going to know what to look for, and you're going to miss an opportunity to make a life-saving, potentially life-changing diagnosis. And non-neoplastic masquerades, we confirm the etiology based on whether or not the patient has their clinical examination, their history and exam findings. Is there an intraocular foreign body in the angle? Look at the do a gonioscopy, look for that if there's a history of trauma. Pigment dispersion syndrome, chronic retinal detachment, these are clinical diagnoses. Next poll question. The patient has poor vision, severe anterior segment inflammation, and a small pupil with a very limited view of the fundus, and the labs are pending. You've done a laboratory evaluation. You don't know what the etiology of the inflammation is. What should you do to treat this patient? Their inflammation is very severe. Should you, number one, start intraocular steroids? Number two, start periocular steroids. Number three, start systemic steroids. Number four, start topical steroids. What's the safest thing to do? And that's really the gist of the question. So the worst thing that you can do when you don't have a view of the posterior pole and you have somebody who has severe inflammation, they have granulomatous KPs, posterior synechia, you can't see anything in the back, you don't know whether they have, and it's a unilateral disease process. You haven't looked in the back of the eye. The worst thing you can do is to give them an intraocular shot of steroids, periocular steroids, or systemic corticosteroids. Why? Because if they have acute retinal necrosis syndrome, you finish the eye. You've made things a lot worse and irretrievably worse in these situations. So if you still are not sure of the etiology, take the safe path out initially until the workup comes back, and then proceed with more aggressive therapy based on your evaluation of the patient. So sometimes you don't have a good idea. Choose an empiric systemic antimicrobial therapy, or even intraocular antimicrobial for the most serious infectious condition that you potentially think that it is. That way you're covering yourself, and then start the topical steroids. And if they don't respond, then add the oral corticosteroids with the antibiotics on board and observe them closely and see how they respond and see how they improve. I think that it's very, very important that you don't make something that is bad irretrievably worse by doing something that will get you into trouble. And that specifically is treating infectious uveitis inappropriately with aggressive corticosteroids without appropriate antimicrobial coverage. So if you have a lack of response or worsening to corticosteroids, you need to think about the fact that, hey, this could be infectious, or this could be a masquerade syndrome. We'll talk more about in a different lecture about therapeutics. I just kind of wanted to touch on it and touch on the importance of why we need to rule out infection versus non-infection. Now, I have a few cases. We're getting late into the talk here, into the last 10 minutes or so, and I will try to wrap this up, but these are important cases I wanted to present, not because I think that these are cases that are your takeaways and really common things, but they're rather very difficult cases that I've seen that I struggled over trying to make a diagnosis. Sometimes these diagnoses takes months to make. Before I do that, let me just look at the question and answers here. There was a question about toxoplasmosis. So if you suspect toxoplasmosis, I generally, if I'm going to do serologic testing, I will check for IgG antibody and IgM both. But if the patient has an old scar and there's adjacent reactivation, then only the IgG is going to be positive. Remember, the IgM is an acute phase kind of, it's from initial exposure, the IgM level will go up, but it will not remain positive for the life of the patient, and it will gradually become negative again. However, that IgG will start going up after initial exposure and go down, but then when re-exposure occurs, only the IgG is antibody response is mounted by the body because of immune memory. And as a result, IgG testing is very important. So I always obtain Toxoplasma IgG antibody. Occasionally will obtain IgM if I think it's a primary acquired toxoplasmosis. More than 50% of worldwide toxoplasmosis is primarily acquired. It's not congenital disease as we used to think. So this is very important to keep in mind. It's an excellent question. How long do you wait before starting systemic steroids? Well, if you think it's infectious, and you put them on antimicrobials, I would start systemic corticosteroids probably within a couple of days, about 48 hours after initiation of antimicrobial therapy. If you don't know whether it's infectious or not, and the laboratory test is unrevealing and the patient's getting worse, and you've just got them on topicals, try to get them on systemic steroids and watch them carefully. And especially if you have a good view of the posterior segment. If you have no view of the posterior segment, that presents a real diagnostic and physical challenge. A lot of times the vision can help us. You know, if the vision is really poor and there's no view of the posterior segment, then you have to assume that there's probably significant problems going on in the posterior segment as well, and not just medial opacities causing problems. When do I think about masquerade syndromes? I think about masquerade syndromes in the presence of, for example, the clinical scenarios in history. And I didn't talk about this very much because this is a very general topic. But if a 70-year-old patient presents with a sudden onset of, or a new onset of uveitis, of vitritis bilaterally with significant vitreous inflammation, then I would think about the possibility of primary intraocular lymphoma. If the patient has a history of nyctalopia and has vitreous cells in both eyes and has bone spiculing, obviously this is a masquerade syndrome where somebody doesn't really have uveitis but has retinitis pigmentosa. So these are based on a clinical diagnosis, clinical appearance, history, and physical examination and ocular examination is going to tell you when you need to consider the possibility of masquerade syndromes. The last question is from, I assume from Turkey here, where I have a question about the IGRA test for TB. It is reliable. I think it's an excellent test. The CDC in the United States has recommended that that replace PPD skin testing completely, but in endemic areas, it can be a little bit tricky because you know, patients have exposure to TB all the time. Places like India, where 25% of patients are walking around potentially who have had some form of latent TB, the IGRA test is going to be positive in those patients. How do you then know that the TB is the underlying cause of uveitis? In many cases, you are stuck with treating the tuberculosis, the latent form of the TB, at least with appropriate anti-tuberculous therapy with the help of an infectious disease specialist, and then at the same time simultaneously putting the patient on appropriate systemic immunomodulatory therapeutic agents like corticosteroids, get the inflammation under control. So I think you have to use your clinical judgment in those cases. The first case that I have is a 27-year-old male who presents with floaters in both eyes and shortness of breath. He's had a 30-pound weight loss over 6 months. He lives in a trailer in a mobile home with several cats. His vision is 20/50 in both eyes. He has granulomatous KPs on his cornea, 3+ cells in the anterior chamber, 2+ flare, 3+ vitreous cells, and cystoid macular edema in both eyes. Here's the fundus examination. You can see the vitritis. There's a little bit of disc edema, and there's also some evidence of choroidal inflammation, as you can see on the fluorescein angiogram. Small, multiple, tiny spots of hyperfluorescent multifocal choroiditis in both eyes. And here's some unusual white fleck-like deposits in the peripheral retina that this patient has. And these are pre-retinal deposits. The laboratory workup is negative for the patient, but radiology testing, chest CT shows severe hyaluradenopathy in the chest. And the patient has pulmonary hypertension. But the lysozyme is normal. The ACE is high normal. Quantiferon and TB and PPD skin test are negative. FTA is negative. Everything else is negative on this patient. So there are multiple enlarged paratracheal lymph nodes on CT scan. Mediastinal lymph nodes are present that are enlarged. His massively dilated main pulmonary artery from his pulmonary hypertension. The pulmonary hypertension is very severe. So we were thinking, hey, this could be sarcoid. He's also got some non-contrasted changes on abdominal CT with an enlarged liver, so he has hepatomegaly as well. And he has periaortic lymph nodes that are present here. There's a little dark arrow pointing to those lymph nodes. So this lymphadenopathy was biopsied because our tissue is the issue, right? We don't have any serologic testing to help us, and the inflammation showed there was granulomous inflammation in the lymph nodes that were biopsied from the chest. And this patient was thought to have sarcoid, and the patient was started on systemic steroids. But inflammation improved initially, but then as the steroids were tapered, the patient worsened. Fevers developed. Fevers. So now we're stuck. We've got somebody who, kind of got better on steroids and then it's getting worse again. Did we miss something? Did we really miss what was going on? Is this infectious? Did we miss it? And it was some sort of indolent infectious process that we're just kind of covering up with the steroids? And these are everyday problems that we see with really severe cases of uveitis where we're trying to figure out what's causing the inflammation. What do we do? So, we still, should we biopsy something else? Should we look again at the lymph nodes? What's our next step? So, because we already done the lymph node biopsy, we felt like there was nothing else externally to biopsies. Perhaps we should look at the vitreous. So we did a vitreous biopsy, and we actually got some of that pre-retinal white material biopsied. And this showed lymphocytes and large macrophages that contained PAS-positive material. And the PCR was performed because we had multiplex PCR available. We were actually able to screen for Trophorema whipplei. This was Whipple's disease. And this patient had very few GI symptoms, but it did have some chronic abdominal pain, some mild diarrhea. This patient ended up having all these PS-positive material in the substantia propria, in the intracellular material, in the duodenal, in the jejunal biopsy that you see here, and this was consistent with Whipple's disease. This patient was managed with rifampin and Bactrim with the taper of his corticosteroids. The corticosteroids were kept in place along with the antibiotic therapy, and the patient has been inflammation. He got better over 6 months and has been inflammation-free and off all meds for more than 10 years now from the onset of the disease. This second case, 79-year-old man with a unilateral severe granulomatous anterior uveitis and vitritis with a hazy view of the posterior pole, 20/40 vision. So this is straight out of your questions that I asked earlier. So you have a very hazy view of the back, 20/40 vision. And the patient apparently had been treated with intraocular steroids, and he got a lot worse. He went from 2400 to 2200 vision to light perception at presentation here with rapid worsening within 2 weeks of that intraocular injection of steroids. Uh-oh. Now our antennas are up. The other eye is normal. It's 20/25. He's pseudophakic in both eyes, and he has anterior chamber cells and a lot of vitritis in the left eye. The right eye is normal. Here's the right eye is normal. But he has a couple little funny scars in the periphery in the right eye. Here's the left eye. Look at this left eye. Hazy view. You see the optic disc? These are intentionally hazy. This is what I saw. It looked just as bad. And in the periphery, I saw all these large white areas. What's happening here? I was very concerned. This could be necrotizing retinitis. This could be necrotizing herpetic retinitis. Or could this be something else? Could this be toxoplasmosis? It's in one eye. It's possible. So I sent off serology, but what am I going to treat this patient with? He's already had intravitreal steroids that made him a lot worse. This is bad. And so this patient has very poor vision. So I decided that the possibilities that are top of the list are necrotizing herpetic retinitis and toxoplasmosis. So what should I do? What should I treat him for? Should I treat him for both? Well, you could do that. I chose the worst thing that it could be. I chose necrotizing herpetic retinitis because that's what I was most concerned about. And I started doing intravitreal injections of antivirals in this patient. I also put the patient on oral anti-toxoplasma medication. I didn't want to take any chances. But in the meantime, I also set him up to have a pars plana vitrectomy and diagnostic vitreous biopsy performed because I think it's important for us then to rule out the possibility of toxoplasmosis or viral etiologies for the retinitis. And indeed, this patient has PCR that was positive for toxoplasmosis. At the time of the vitrectomy, I empirically gave him clindamycin and ganciclovir, but a couple of days later, he was known to have toxoplasmosis. This was a patient who had Toxoplasma Retinochoroiditis, where there was no view of the posterior pole, and the patient was inappropriately given intravitreal corticosteroids. Made much worse and the patient ended up with not a blind eye. We were able to salvage vision. He got back up to about 20/70 when I last saw him a few years ago. So, you know, he had chronic cystoid macular edema, but at least better than light perception vision. But this patient's retina looked like this after we were all done with the vitrectomy, and he healed. There's some laser scars around the edge of the retinitis here, but there's large spots of retina. Fortunately, you know, he didn't wipe out the entire posterior pole. But you can really make somebody much worse by putting them on inappropriate corticosteroid therapy if it's infectious. So treat with antimicrobials and then add the corticosteroids. Never give intravitreal periocular corticosteroids without appropriate antibiotic coverage if infection is even remotely suspected. And in the case of infectious uveitis, if you don't have serologic diagnosis, tissue is often the issue to make the diagnosis correctly. Here's another, this is the last case that we'll do, so we can wrap things up, and I'll check on the question answers after this case. 69-year-old, a white female with painless subacute vision loss over 1 week in both eyes, had metamorphopsia and a few floaters and no photopsia. She's only had a previous history of hypertension. But on review of symptoms, she complains of severe pleuritic pain, dyspnea, and she's had weight loss and arthralgias involving her hands and her feet. Vision is 20/60 in both eyes. The conjunctiva is quiet looking. The anterior chamber just has a few cells in each eye, 0.5 cell, and 1+ vitritis in both eyes. And the retina has evidence of disc hyperemia and serous retinal detachment of the posterior pole in each eye. There's no peripheral choroidal lesions that are seen, and there's no vasculitis that's seen. But there's a serous detachment that these arrows are trying to point out. That's not a great picture because it's a little hazy. And there's a serous detachment around the macula in the fellow eye, the left eye as well. And here's what the fluorescein looked like. Starry sky pattern of you know, peripapillary and posterior pole choroidal lesions that leak and pooling of fluorescein in the subretinal space. Oh, is this VKH? This is what it kind of looks like. But she has dyspnea and she has weight loss. That's not typical for Vogt-Koyanagi-Harada syndrome. And sympathetic ophthalmia, well, she has no history of trauma or previous surgery or anything. It can't be that. So what is this? This is weird. So how should I do? What kind of things should I do in the workup? Well, sarcoid, syphilis, TB is still important to rule out, obviously. Here's the other eye, same kind of clinical picture. Very interesting picture here. So she had no history of hearing loss, vitiligo, poliosis, anything to suggest VKH. Everything that we did, the PPD skin test, FTA, ACE, lysozyme, chest X, were all negative, but the chest X-ray I did get for the dyspnea. And this revealed that the patient had bilateral pleural effusions. And I went back then and obtained an anti-nuclear antibody on this patient. It was very, very high. And the double-stranded DNA antibody was high as well. And the pleural fluid was biopsied and showed a very high positive anti-nuclear antibody titer. She had mild proteinuria and urinalysis, and this patient had lupus, and she presented with lupus choroidopathy. She had met more than 4 out of the 11 diagnostic criteria. So this is very important to keep in mind, that the diagnostic criteria are what's used to make the clinical diagnosis of lupus. The blood tests were an afterthought, frankly. I normally don't get blood testing for lupus for uveitis patients unless they're, as I told you before, unless they're a child and I'm suspecting that they have pauciarticular JIA. Or if, in this case, if they had vasculitis. Lupus choroidopathy is a very, very rare condition. I didn't bring this up because of the rarity, but you can see that we need to use pattern recognition to help us go in the right direction for a diagnosis and then choose the appropriate testing based on what the clinical appearance is. The patient that was treated with systemic corticosteroids, Imuran, has had durable remission and disease-free now for more than 15 years. I'm going to stop there, and I'm going to look at the questions. I wanted to thank you all for your kind attention. So somebody asked, what is the percentage of idiopathic uveitis with negative labs? Now, the party line among uveitis specialists in the United States, I would say that about 50 to 60% of patients that we see have a laboratory workup that is negative, and they have so-called idiopathic uveitis. So this is an excellent question. You know, the vast majority of patients are going to have a negative workup. That doesn't mean that, you know, that there's no cause for the inflammation, or there's some mysterious thing. many of these patients may have had an initial exposure, as I said, to some environmental antigen or some environmental pathogen that induced the inflammatory process to begin with, and because they were genetically predisposed to the inflammation, and then that started a series of cyclical immunologic events inside the eye that caused chronic inflammation to develop. And that's the way I kind of understand it when I can't, and that's why I try to tell patients when I don't have an underlying cause and we're treating the disease but not really treating the underlying cause. So there's a few more questions here. Why you do every patient with uveitis intermediate with an MRT to exclude multiple sclerosis? Oh, would you do, excuse me. So yeah, so intermediate uveitis and its association with multiple sclerosis is an excellent point that somebody brought up. We know that ophthalmic literature suggests that between 5 to 15% of patients with intermediate uveitis may have associated multiple sclerosis. And similarly, the data works the other way. About 10% or so of patients with multiple sclerosis actually have intermediate uveitis. So, in these cases, I am careful to ask the patient on review systems about neurologic symptoms. If they have intermediate uveitis on the examination, I'll go back in my review systems and ask them, have you had neurologic symptoms? Have you had evidence of, a neuropathy that lasted for 6 weeks or went away? A weakness or numbness in an extremity that lasted for some time and went away? History of optic neuritis. If they give a clinical history of that, then I would say, yes, we need to then evaluate the patient for multiple sclerosis, and I would refer them to a neurologist for evaluation. I would, in that situation, not do the MRI and not evaluate them myself, because there are numerous questions that then arise if they have MS in terms of how they should be best managed, and a neurologist who's expert in the treatment of multiple sclerosis should do the testing and evaluation and treatment of that patient. I use cycloplegics always when the patient has acute anterior uveitis. I almost never not use cycloplegics, and we will talk more about this in the therapeutic section, but I use it religiously. Cycloplegics, usually for milder inflammation, I'll use cyclopentolate. For severe inflammation, such as HLA-B27 hypopyon uveitis, I'll often use atropine initially and switch to something milder once the inflammation has gotten better controlled. Is there any alternative to HLA testing for resource-poor countries? Well, I think if you suspect that the patient has spondyloarthropathies or seronegative spondyloarthropathies, HLA testing isn't essential, but an X-ray of the involved joints, for example, a sacroiliac joint film, can be very helpful in determining whether the patient has underlying sacroiliitis. In recent reports have suggested that up to 50% of patients who have HLA-B27 positive hypopyon uveitis actually have some demonstrable changes of sacroiliitis in their joint film. So I think that would be a reasonable screening tool if you do not have HLA testing available. For severe inflammation and TB uveitis, of course you have to use steroids, but you have to use steroids only in the presence of appropriate anti-tuberculous therapy. Okay, what blood tests for lymphoma, leukemia, choroiditis? There aren't any reliable blood tests for lymphoma or leukemia. Now, if the patient has severe leukemia and has a complete blood count and a differential and an actual plated differential, where a pathologist actually looks at the peripheral smear of the blood, is very helpful in making the diagnosis of leukemia if there's leukemic infiltrates in the eye. Sometimes we'll use aqueous or vitreous sample, of course, to make the definitive diagnosis if we don't have any systemic things going on and the lymphoma is isolated only to the eye. Remember that primary intraocular lymphoma presents only in the eye in 20–25% of patients. So that may be the first presentation. So we rely on biopsy, vitreous biopsy in those cases. If the cornea is involved, how will it affect management? I think that the question probably is related to herpetic disease or corneal epithelial defects and using corticosteroids. And so this is an excellent question. So if the patient has herpetic disease and has a corneal epithelial defect, and has significant anterior segment inflammation, usually I will put those patients on systemic antivirals, because those are highly effective, especially against HSV, for example, to cause the epithelium to heal, so that then we can use the topical steroids. I will probably not, I would be very careful about using topical steroids in the presence of an epithelial defect if I'm considering the possibility that the epithelial defect is due to herpetic disease or other infectious entities. And of course, if you have a hypopyon in a patient who has a epithelial defect and some mild corneal infiltrate, this could be an infectious keratitis and not at all a uveitis. The uveitis may be secondary to a keratitis, so please keep that in mind. In patients who have uveitis with anterior uveitis and posterior uveitis active cells with optic nerve head swelling, should we do a brain MRI? You know, this is a very good question, because the optic nerve head swelling is quite common in patients who have intermediate uveitis, and even anterior uveitis, I've seen it as well. So this is an effect probably because the peripapillary choroid has been inflamed, and perhaps some of the peripapillary retinal vessels have been inflamed. This is resulting in the disc edema in most cases. Now, there are some cases where the disc edema is very, very severe, and in those cases, the patient may truly have a second disease in addition to the uveitis. I have a JIA patient, for example, who had severe pseudotumor. And that patient required an LP, an opening pressure evaluation, and to rule out the pseudotumor. And indeed, he had pseudotumor. He had to be treated with systemic Diamox along with immunosuppressives. You know, what investigations can you do if you have somebody who has a post-flu vaccine shot-associated neuroretinitis? I don't know of any. In these cases, it's your clinical gestalt, your clinical impression that is going to actually make you go along the lines that, hey, this neuroretinitis is related to something, not the typical thing. But in those cases, I would still rule out the possibility of Bartonella, okay? I would still rule out other syphilis, Bartonella, and even TB. Those kinds of things can certainly cause neuroretinitis as well. How do we diagnose intermediate uveitis in the setting of sarcoidosis? You know, sarcoid can certainly cause intermediate uveitis. Remember that sarcoid is quote-unquote an autoimmune disease. How you treat it, whether it's idiopathic intermediate uveitis or sarcoid uveitis, is not going to make any difference. But I think the diagnosis is really going to be based on the presence of obtainable tissue biopsy. Looking at the conjunctiva before you put the patient on topical corticosteroids, which can cause the conjunctival granulomas to melt away. Look at the conjunctiva in the inferior fornix, flip the lid, look underneath the lids at the conjunctiva, at the bulbar conjunctiva, look for granulomas. If you can make a tissue diagnosis of sarcoid, it is immensely helpful going forward with systemic therapy. For VKH patients with bilateral optic nerve head swelling, do we need brain MRI? No. In that setting, no, unless the patient has other neurologic symptoms. And many patients do have meningismus, but if they have classic features of VKH and optic nerve head swelling, I do not do an MRI in those patients, nor do I necessarily recommend a lumbar puncture. So this is, again, a clinical diagnosis. Would you take a conj biopsy if there are no nodules? No, I always look for nodules. I do not do blind conjunctival biopsy. The yield, if you read some of the reports from Ralph Eagle, who has probably had the largest series of blind conjunctival biopsy, the yield is very, very low. So you should look for granulomas. These granulomas are going to be different from the typical conjunctival follicles. They're going to look larger. They're going to be more kind of fleshy looking, and they'll be pretty obvious. These are conjunctival granulomas, and it's surprising how often that's missed. So I always look at the conjunctiva. Dr. Ron Smith, my old mentor, used to tell me, you know, that if you don't look at the conjunctiva as a uveitis specialist, it's like not doing a peripheral retinal examination with scleral depression as being a retina specialist. So it's very, very essential in uveitis to look at the conjunctiva. The role of doxycycline in post-chikungunya and rickettsial neuroretinitis. I have very little experience in post-chikungunya, but I can tell you that rickettsial neuroretinitis, rickettsia should be treated with doxycycline. Doxycycline as an antibiotic cover is very important before the initiation of corticosteroid therapy for the treatment of the optic nerve head inflammation. Which part of the conjunctiva would you most likely find nodules? Well, most of the time we find nodules in the inferior fornix. Usually on the in the fornicule between the bulbar and the palpebral conjunctiva in that area. But I also look underneath the upper lid. I'm going to break it off here. It's about 10:15. I want to thank you for your excellent questions and your involvement. I hope you could hear me well, and I really enjoyed this. I hope I always learn something from all your questions. So I look forward to the next next session. Thank you very much.